I do. I want to thank the program committee for inviting me to talk on this subject. I look out at the audience of my esteemed colleagues out here, and I see people who have been doing this a lot longer than I and have a lot of experience. So I wanted to kind of make this somewhat a little bit interactive, and I do want to say that these views aren't, as Dr. Sanders said, the views of the Army, the Department of Defense. I don't have any financial disclosures, and it's only for education and professional purposes. However, that's not really necessarily true. I probably have the biggest financial disclosure, and that's that I'm fully funded by every one of you here, so I appreciate that. So I guess you'll see, based on this presentation, whether your taxes are being well used. So let's start with a case study. This is the problem of bariatric surgery, and specifically sleeve gastrectomy, is that you have two things. You have sleeve gastrectomies increasing in terms of the performance of that operation, and revisions are also increasing. Some people question, is there a correlation between those two? But we all see, I think for the most part in our practices, cases such as this. You can see the details on there: 3-year status post-sleeve gastrectomy, refractory reflux. You have the upper GI that you've seen there. It appears as if there's a stricture. She has an upper endoscopy, which shows esophagitis. She's now at a BMI of 37 after gaining a lot of weight over the last year, where she natered at 27. So by a show of hands, who would revise this patient? All right. Most would. The next question is, what do you revise it to? By show of hands, gastric bypass. Who would revise it to a gastric bypass? Yeah, majority. Who would stent this patient? All right, few. How about a dilation? Mini gastric bypass? There we go. I knew I'd have some. Seromyotomy. And magnetic sphincter augmentation, to avoid industry names. All right. And like Dr. Blackstone said, conversion and corrective. Those are the two terms that we're going to talk about. And here's the definition. So a conversion is actually switching from a different index procedure versus a corrective procedure, which that's a nice politically correct way of saying we kind of screwed up the first operation. Or something happened with the first operation. We had gastric or sleeve dilation, a hiatal hernia that now has appeared. And then, of course, there's also reversals where you restore the original anatomy. So let's look at the scope of the problem. As we've seen on multiple slides, it is a reversal revisions have increased 217% since 2011 to 2016. And specifically looking at sleeves, sleeve revisions, the reasons for revision: bleeding, the sleeve's too big, it's too narrow, it's strictured, it's too angulated, or it develops a leak. It's interesting, how many people have had a leak at greater than 2 years after the index operation? Yeah, I did too. Patient on methotrexate that we did a sleeve gastrectomy on, rather than a bypass, because we were worried, obviously, with their autoimmune deficiencies. So you can have those things. And when giving a presentation, it's always important to include studies done by some of the co-chairs and the chairs of your presentation. And this actually was done in New York. And it's actually recent data, which is very nice, coming out just this past year, and looked at New York's data. And one thing I want to highlight down there is that 60% went to another facility for your revision. So if you think your revision rate is low, it's probably that you're just not seeing your revisions. And if you think everybody else is having revisions except for you, it's probably because they are. And so all of us are having this, and it's becoming a bigger and bigger concern. And then they also look to see what specifically sleeves were revised to, and you can see the numbers here. And I did find it that the duodenal switch and the gastric bypass were the leading revision procedures, convertive procedures. This was also interesting. As you look here, we have the triple threat, right? You go from a band to a sleeve to a bypass, or a band to a bypass to a duodenal switch. And people that have had a single sleeve gastrectomy, most people have had most of the people have only had one conversion. However, if they're twice as likely to have a second operation than if they've had a gastric bypass as their index operation. So it was nice to tease out some of these numbers to identify, if you're doing sleeve gastrectomies, that there's a higher likelihood that you'll do a second revision with a sleeve gastrectomy than if you were to start out with a gastric bypass. And this goes into something that Dr. Hutter said, is why do we revise? Is it inadequate weight loss, weight regain, refractory comorbidity conditions? So it's similar to weight loss, like the comorbidity didn't go away, the diabetes didn't go away, the hypertension didn't go away, or did those comorbid conditions come back? Or is there reflux, dysphagia, or pain? And then we have to identify what goals we had. Well, if it was inadequate weight loss, we'd like to see weight loss. And you can see, so this is really a spectrum, and sometimes it's multiple elements of this. So this is the algorithm I kind of use in our practice as I approach these patients. And you look and you see this problem patient. Dr. Hutter was talking about the frowny face and the smiley face. Well, the problem patient comes in and they've called your clinic multiple times, your colleagues are getting called, they're having all this reflux. And what we need to do as surgeons is take it away from the patient and really look at what is the problem. And that can be subdivided to kind of 3 main categories, 3 to 5, depending on if you're using comorbidities. Reflux, and these same ones that I just mentioned. Now, these two can be divided into lifestyle, diet, or anatomy, right? Are they having these issues because of their lifestyle, their diet, or is there an anatomic problem that you need to correct that either has developed or was pre-existing and now it's unmasked? Now, when you look at the anatomy picture, if you try to solve one of these by changing the anatomy once again, the likelihood is that you'll fail. You see some data a little bit in the fruit salad of data that supports that. But the anatomy, these are kind of the anatomic issues that we have when you're looking at sleeves. And I include a physiologic factor in here as well when you look at dysmotility. So all of these combined can lead to a maladaptive eating, which in turn can lead to some of these other conditions. So you really have to look at this. And then you have to diagnose whether it indeed is one of these or not. How many of you get manometry prior to a sleeve correction or conversion? Yeah. I think if you were to ask that a couple years ago, especially with reimbursements and things, I don't think many people would say that. I don't think, but now it looks like almost the majority of people will get manometry prior to that. Because if you're trying to fix a dysmotility problem, either a patient's had a chronic stricture and now they have esophageal dilation, and then you try to fix that with some other means, especially if you're going to re-sleeve, which is now I've seen some publications come out about re-sleeving and things like that. You make it a more restrictive process. I think you're going to exacerbate your problem. And don't forget, if you're going to do a revision surgery, we only fix this box. So if you're trying to fix these, or you haven't investigated these, and you try to do this, you'll likely end up in a second or third conversion. So here's some images, hiatal hernias, strictures. There's a large antrum, whether this was created this way, or certainly there's an issue with this. And so we have a spectrum as well, whether you're doing a corrective operation or you're doing a convertive operation. And again, those definitions, corrective, you're trying to fix something and maintain your original intent for the index operation versus convertive, where you're actually changing that index operation. And the reason this is important is because there's significant data that some pretty profound people have gone in and done the work to find, and that there is some statistical significance between convertive operations and corrective operations. And so you have some, if you're actually doing conversions, which, and I believe there's purpose to do, you have to understand going into it that there's actually mortality and significant adverse event results of that. So keep in mind that this is the algorithm that we kind of look at as we're going to now dive into the fruit salad of the data. And this is really, it looks kind of confusing, and there's a lot of data, and you'll see, and we'll just highlight that quickly, that it is sort of fruit salad. But it's really a good news story, right? Because we've come so far in bariatric surgery and our practice of that our complication rate is driven down to single digits to some extent. So to be able to generate significant data requires large patient volume. And so what you'll see here is large patients, but small cohorts. So when I start off with dilation for strictures, we have both balloon dilation and savory dilation. So, and by poll, I'm just curious, how many do balloon dilations as part of their practice routinely? And how about savory dilators? Okay. How many don't do dilations? And because of your practice mix, the gastroenterologists do that. Okay, so a significant amount. And those are issues as you're looking at your algorithm of revising sleeves or correcting or converting sleeves that you have to keep in mind. Are you dependent on because of the setup of your practice, are you dependent on another service line to be able to help you out with that? So stenting, this is some data from the Cleveland Clinic. They went through and they looked at their stent complication rate and the numbers of patients that have been stented. This is a few years ago. The majority of these were actually bypass patients, but there was a subset of sleeve patients. And out of these 18 patients, and when you look at probably anywhere from 2 to 6% complication rate, to generate 18 patients, that usually takes about 900 patients. So, and that goes into the fruit salad bit of when you're trying to generate large numbers of complications, you have to have a huge number of total operations. So when they looked at those 13% complete resolution after the endoscopic stents. 1 of 3 strictures were completely resolved from that. This is a plug from other military institution up here actually in Seattle with Madigan Army Medical Center. They actually looked at reflux and sleeve gastrectomy, which is a whole topic of another session this afternoon, which I hope you come to. And they actually did some magnetic sphincter augmentation with magnetic beads around the sphincter to see their outcomes, and you actually end up with a significant quality improvement after magnetic augmentation around the lower esophageal sphincter with 73% quality improvement for your bariatric patients. They set this up, 27 patients total, 10 were bariatric patients and 17 were non-bariatric patients with standard indications for anti-reflux procedures. And then seromyotomy. Not many people do this. I think a few years ago, there was some people that were into that. I noticed Dr. Higa did a video abstract last year, and so which actually had the sleeve followed by balloon, followed by seromyotomy, then followed by gastric bypass. So it can be done in very talented hands. And you look at Dr. Dupree's and colleagues, his series, 9 patients, 1 leak. Again, the statistical significance of 9 patients and 1 leak, I don't know if that's necessarily statistically significant, small studies like Dr. Hutter was saying. and then Dr. Eubanks as well, and back in 2006. So you see that these are a little bit older studies. I don't think many people, as our poll demonstrated, are doing this. Now, what about convertive operations? So we have these studies that we'll look through very briefly. Look at Dr. Chung's data that we looked at, and speaking especially here near Canada, they looked at their results. And this is actually from 2014. They did a meta-analysis of 11 studies, 218 patients, which I think our most significant data in our field is going to come out from these large conglomerated studies until we can have use MBSA QIP as a long-term platform for looking at revisional surgery. So he grouped these revisional patients into who underwent a gastric bypass after a sleeve, who were re-sleeved, and then other surgical intervention, which was primarily BPDs with duodenal switches. Again, this is a little bit older data. Here's the outcomes from this, and this is the BMI curves, where you look at the starting point of the re-sleeved patients. They actually end up almost the same point when they started after being re-sleeved. The bypasses, they start higher. They're statistically significantly at starting at a higher BMI and ending up in lower BMI. And then the duodenal switches and other surgical interventions actually had a pretty statistically significant improvement in their BMI scores, which I think other data would support. Here we have sleeve to gastric bypass. This is a Kaiser Permanente study by Dr. Casillas. And this also looked at the overall complication rate and analyzed the indications. And so here we have the percent excess weight loss. You start here and you end up probably a little lower or about the same as your same percent excess weight loss as you started. I think there's problems with looking at percent excess weight loss. I agree that as you get into higher BMIs and higher weight categories, that percentage skews what we're looking at percent excess weight loss. But this is the take-home point from this slide, and that's that the patients that, when they did the subgroup analysis, the patients that underwent a revisional operation for either poor weight loss or with GERD or poor weight loss alone, anything that included poor weight loss, their success rate in terms of excess weight loss was statistically lower than the rest of the cohorts. So when we look at why we're doing it, and I think this goes back to that algorithm that I think sometimes we're trying to solve either lifestyle or diet issues with a surgery, and it doesn't necessarily say that we're addressing all three of those domains, which I think you really do need to address all three of those domains. And then they also looked at the complication rate. They looked at 30% complication rate after this for this study. And here it kind of breaks it down. You hear 30% complication rate and you think that that's pretty high, but you're looking at stuff like readmissions for nausea and vomiting and these short-term complications, which I think we're all willing to tolerate. So these are not significant adverse events. Dr. Phoebe and his colleagues that we mentioned previously, he did, this is a poster that was presented last year at ASMBS, and they looked at 74 sleeve patients that underwent either banded gastric bypass, a mini gastric bypass, or were converted to a banded gastric bypass. And this was the analysis they had, that the re-sleeved patients, all of them lost weight to a year. The re-sleeved patients gained weight after that. The mini gastric bypass patients maintained their weight loss, similar to the banded study that we looked at earlier. And then the banded gastric bypass patients continued to lose weight. So, which you would expect based on the data that was just presented to us, but also at the investigators' findings as well. And then this is the last study we'll look through. And this looked at sleeve to a single anastomosis duodenal ileo bypass. And this is kind of the new kid on the block. We're still investigating this in terms of ASMBS and looking at novel pathways, and this is an innovative procedure. But certainly if you go to Utah and you talk to Dr. Cottom or some of the other experts down there, they have fully embraced this approach to sleeve gastrectomy, which is here. Again, we have 15 patients. These were all initially sleeve gastrectomies, and in a small subset, they decided to do this single anastomosis duodenal ileal bypass as their revision. So they looked at 15 patients out of this data set, which again is small, that fruit salad, and they have anywhere from 3-month follow-up to 36 months. All those seem to be trending in the right direction, and as you look through data, it seems like it's trending in the right direction, but again, these are such small studies that it's hard to make any significance of that. Certainly there's complications associated with that. This is just an analysis of his just the nutritional deficiencies. And you see after, this is when they just had their sleeve, very minimal nutrition deficiencies, and after their revision procedure, some significant nutritional deficiencies. So summation, there's a lot of question marks here. I kind of wanted to pull it together, and my intent was to say, hey, look, if I were sitting in the audience, I'd want to just see a graph and say, which one do I do? And so as I started to make this graph, I was like, well, I can't really say this because there's not really statistical significance, and well, that's okay, but then this is good, and so the bottom line is there's a lot of question marks, and none are statistically significant. And but what is statistically significant? I go back to this study that we looked at the BOLD database, and they have 400,000 patients, and of those, they looked at corrections and conversions. And here we have, these are the index operations, and these are the ones that were converted. And pulling this out, here's sleeve gastrectomy, which is the focus of this talk, and you have 347 patients, 4%, and this is prior, 2012, to a lot of this duodenal switch business, but a lot of them are getting converted duodenal switches. And the question I would have, because this is just retrospective, this is looking at us, and then you're looking at why are we doing that? Like, certainly we're choosing to do that. We're the surgeons, we're driving this, and we're driving this data. So our practice tends to shift towards this. Why is it not more? I have my own thoughts about that. But again, it comes back to this point right here. The only thing we really do know with statistical significance is that to be doing these operations, you need to have the expertise to do them, but there's certainly conversions. If you're going to convert, it's important to have the expertise that's consummate to that. And to address these 3 domains, because if you just address this one, I think you're going to run into trouble. Thank you very much.